We're going to be today talking about hot topics in human milk feeding, and the speakers are myself, Jenny Tender, Dr. Jessica Nash, and Dr. Earl Harley. Do the next slide, Jess. Are you able to forward it? All right. So the objectives are first is to identify two causes of poor weight gain in human milk fed infants, to identify achalaglossia and determine when treatment is needed, to identify and manage allergic proctocolitis, to describe what resources are lactation resources are available for DC providers and families, and to identify key barriers to treatment for minority or underrepresented groups. So I'm going to give you a little bit of an outline so you can kind of follow along. It's going to be a whirlwind. First, we're going to go over the DC breastfeeding needs assessment. Dr. Nash is going to discuss a breastfeeding case. Dr. Harley is going to discuss tongue-tied. I'm going to discuss food protein-induced allergic proctocolitis and jaundice. And then Dr. Nash is going to finish up with cannabis use and resources. So, none of us have anything to disclose except those are very cute Dr. Nash children. Alrighty, so the DC Breastfeeding Needs Assessment was conducted in partnership with the DC Breastfeeding Coalition with funding from DC Health. And as a background, the reason we decided to conduct the study is that, first of all, there was very little consistent data about DC human milk feeding rates. But the one thing we did know is that there was racial and economic and ward level disparities for human milk feeding at 8 weeks, according to the PRAM survey. And families who are Black, receiving Medicaid, and living in wards 5, 7, and 8 have the lowest rates of breastfeeding in DC. So we decided, go ahead if you want to change. We decided that if we wanted to really determine how to improve the breastfeeding rate, we first of all needed to assess what the barriers and gaps were in breastfeeding in DC. So we conducted a mixed method study between April of 24 and February of 25. We surveyed two groups, parents and providers. For the parents, the children were less than 2 years old living in DC, and we surveyed them two ways through either a paid panel on Qualtrics, and then we also recruited 120 families in areas that have historically low breastfeeding rates. And then we also conducted 15 focus groups with a total of 65 parents, and 3 of those groups were in Spanish. For the providers, we surveyed 68 providers from maternal and child health care providers, WIC staff, and lactation support. Next slide. And then our findings were that 90% of moms initiated breastfeeding in the hospital. Almost 3/4 of those who did not provide human milk to their baby, they wanted to do so, and 9% reported that they provided donor milk in the hospital. And for those who had stopped breastfeeding, the 62 women who had stopped breastfeeding, about 10% breastfed for less than a month, a third breastfed for 1 to 6 months, almost 50% from 7 to 12 months, and about 10% for more than 12 months. And what we also found is that there's a need for education about common breastfeeding challenges for both the parents and the families and support networks, because those were the top groups that parents relied on for information. We found that fewer than 1 in 3 parents reported that their obstetric provider discussed breastfeeding during prenatal care. And one of the illustrative quotes was, I was asked about my plans to breastfeed or formula feed as kind of a part of checklist, usually by a tech before my actual appointment. I also saw midwives. I never had a conversation about breastfeeding with anyone in the prenatal stage. Next slide. For in-hospital formula supplementation, about half of respondents said that they received formula in the hospital, and the most common reasons where they felt their baby had poor latch, they were concerned about insufficient milk supply, it was a personal preference, or the parent experienced pain. Often things that we can remedy, that providers can do some remedying with. After babies were discharged, almost 40% said they had breastfeeding difficulties. And one-third of respondents said they stopped breastfeeding earlier than they wanted to. And the top reasons were that they needed to go back to work or school, or they weren't receiving timely support when they needed it. And another quote was, I chose to stop this time around because I didn't know what else to do to stop the pain. I felt like I was failed by those medical providers. For the provider barriers, the obstetrician said that they had limited time, lack of reimbursement, insufficient knowledge, and not enough access to lactation specialists. Primary care providers said they didn't have time or expertise, and lactation support providers and WIC providers felt that it was difficulty getting breast pumps and finding providers who accept Medicaid recipients. If you want to go on. So some of our recommendations, the first one is to establish closed loop referral systems from the hospital to within medical systems on the outpatient. Second, next slide. And to it makes sure that hospital staff and we're well educated about breastfeeding with a special emphasis on making sure they have practical support to help families and that they're competent in their knowledge, to expand access to donor milk within the hospital, and to make sure that birth parents who are at risk for challenges are identified early and then referred upon discharge to appropriate services. At the provider level, we wanted to make sure that there is improved provider education with hands-on training in breastfeeding support and counseling, and then also to have a task force led by obstetric providers to figure out ways to develop efficient, comprehensive models for prenatal breastfeeding education for families. On the policy level, making sure that working parents have access to appropriate, adequate paid parental leave, and that employers and employees and everyone knows about the breastfeeding laws and that the laws are enforced, and also to support and develop strategies to integrate more lactation specialists into outpatient care settings, especially for those families that are residing in wards 5, 7, and 8. The limitations are that the paid panel respondents that from the Qualtrics did not represent the demographic makeup of Washington, D.C. It was a higher rate of white and commercial insurance, and that it was a small sample size. If you want to So we're going to now, assuming one of the things that we found in the needs assessment was that providers needed more education and specifically on how to handle medical issues and challenges. And so I'm going to pass this over to my colleague, Dr. Nash, to talk about a case about breastfeeding challenges.
Thank you, Jenny. Sorry, my screen is being finicky. And so this is really important, given that this information, which none of it is really new or shocking, but again, just sheds the light on where we are and things that we can help with again, the protection, promotion, and the support of breastfeeding. This slide here says pediatricians, but really this is anyone who is caring for families. We really need to be able to assess effective breastfeeding and manage common problems and provide guidance. We need to know where and who to refer. And we need to collaborate if we aren't able to help. But overall, the maternal health providers can collaborate to improve the care of the infant and mother. And so one of the things we know, risk for early breastfeeding cessation, reasons why moms quit, which was also highlighted in the DC Needs Assessment, was pain with latch, the perception of inadequate production, and the perceived need to supplement. reported insufficient milk supply, meaning there may not really be an insufficiency, which still remains the most common reason for early formula introduction. And so we have a case here. This is Noah, a 6-day-old former 3.4 kilo infant born at 40 weeks via non-spontaneous vaginal delivery to a mom who was G1P1, and the pregnancy was otherwise uncomplicated. We know today his weight is 3.2 kilos. He's feeding every 3 to 4 hours, about 6 to 7 feeds a day. As far as latch issue, feeds start okay, but become painful. Baby frequently falls asleep at the breast, and feeds last 45 to 60 minutes, but the baby still seems hungry after. Mom is unsure if she is making enough milk, occasionally offering formula bottle after feeds 1 to 2 times a day. So a common thing that we commonly see when babies come in for their first pediatric visit in an outpatient pediatric setting. And so addressing some of the parental concerns is mom is asking, is Noah getting enough milk? And then Noah's mom, birth parent, is asking, I'm having some significant pain with breastfeeding or chest feeding. Maybe someone might have mentioned in the hospital, is it because Noah has a tongue tie? Is that why I'm not getting enough milk? And so one of the first questions that we address is Noah getting enough milk? And so we kind of need some additional information. So we have already kind of asked how often is he feeding, but maybe need to ask some more questions around how often is he urinating and stooling? What do those stools look like? Have the stools transitioned in color to the black terry stools, to that yellow mustardy pasty stool? And then again, looking at weight loss versus weight gain. And so, obviously, how often should they nurse? So, on demand, and this mom is saying, oh, I'm nursing every 3 to 4 hours, which kind of sounds about right. But we know with effective nursing, nursing around 8 to 12 times is the most effective in 24 hours. And so, this mom is nursing, I think we said about 6 to 7 times, and we need her on the higher end, somewhere between 10 and 12 times to have effective nursing. One of the things that came out of this article from the maternal and child nutrition is diagnosing breastfeeding difficulties and where do we stand. And so this becomes this cycle or wheel where mom is having this feeding anxiety and loss of confidence. There is decreased milk removal from the breast because maybe the baby isn't at the breast frequently enough. But also, then mom starts to have a low milk supply and is also doing some formula supplementation. And then we have some infant weight loss. And all of this, if we don't intervene at any of these points, can lead to decreased weight loss, but also could lead to doing more formula supplementation. And obviously, a lot of this breakdown is centered around inadequate breastfeeding support. And this is where we as health providers can intervene at any time and hopefully earlier rather than later. Other reasons, if it's not related to infrequent or not effective nursing, so maybe the one tool we realize is that mom isn't feeding the baby enough. And so that's where we jump in. But there are other reasons for not getting enough milk that we may need to just add some particular questions about. I think pediatricians don't always necessarily think about these, but thinking about retained placenta. So, how was the delivery? If there's any placenta that is retained, even a small amount, it delays lactogenesis, which can delay breast milk. Thinking about has the mom and asking those questions. Have you had any types of breast surgeries? In particular, things like reductions, breast reductions may decrease some of the tissue that mom has, but also thinking about things like what type of augmentation surgeries has the mother had, and could that be a reason? We also need to know about some of the paternal medical history. So, is there a history of hypothyroidism? Did this parent have IVF because maybe there were issues of like PCOS? And so, obviously, PCOS can cause just even delayed memory tissue developing. And so, they may not have that sensation of breast fullness when they are pregnant, which then can cause a decrease in breast milk. But also with insulin resistance, there can be a decrease in breast milk. And then obviously we should be thinking about medications. Are there any medications the mom is taking that could be interfering with supply? But one of the biggest things that we should think about from this case is pain with breastfeeding. And obviously, the number one, two, and three reasons related to pain with breastfeeding is poor latch. So, number one, poor latch. Number two, poor latch. Number three, poor latch. Now, obviously, two could be related to positioning. So, just helping a parent with positioning can help with the latch. And then, obviously, poor latch related to tongue tie. But we should really be thinking about what does the latch look like? Obviously, there are other causes that we should consider, like thrush. Is the mom having, does the baby have some thrush in the mouth? Does the mom have cracked nipples because there's thrush on the nipple? Obviously, things like bacterial infection, there could be vasospasm of the nipple. And then the only way to really get an assessment of this is you have to examine the baby and watch the baby nurse. And so this is a tool that we want to help people with. And so the management strategy is assessing and correcting latch. So you want to encourage the nose to the nipple alignment. You want to ensure that there's a deep latch, making sure it's not just the baby on the nipple, but the baby has some of the areola and that the lips are flanged. You want to make sure that mom is comfortable in this laid back position. You want to make sure that mom is able to use the correct sandwich technique, and you want to check for effective milk transfer and encourage that mom continue to do more frequent feeds. And I know that all sounds like a handful if you aren't used to doing it. And I have a video that I hope I can play that will help. Let's see. Are you guys able to tell me you can hear the sound? Can someone say yes?
I can't hear any
I
sound.
can't hear it. Mm-mm.
Okay, let's see. Sorry, guys. Let me stop my share. And then I think I do have to go to audio and let me see. Anyone know what it is? It is on the share video, videos and effects.
You could
Keith,
probably narrate, Jessica. Doc, assuming.
I think maybe I'm gonna have to.
Hmm.
All right, let me just go to video settings last just to make sure. But if not, I'm going to narrate. All right, let me share my screen again. All right, can you guys see my screen?
Yeah.
Awesome. All right, so this is a cradle hold. You have a nice tight C behind the base of the skull of the baby. So you can direct the baby, but not forcing the baby to the breast. And just like we talked about, nipple to nose. And you want his head tipped up and the chin into the breast tissue, not the nose to the breast tissue. And if you have the baby too high, the nipple is pointing down to the tongue versus you want the nipple to the back of the pharynx. When you're nursing off of the left breast, you're going to use your left hand. And just like how you hold a cup with a C shape, that's how you mold the hand. And you turn your hand under and you make a C with the breast, a comfortable C. And you can see the mom has more of an oval shape versus a circular shape. And the oval helps to open when the baby opens the mouth wide to latch right in that location where she is massaging. And when the latch at that position, when you massage, the milk comes out nicely. And obviously, when you latch on too high up close to the nipple, you aren't able to massage the breast tissue and get the milk out. And also it's painful if you latch too close to the nipple. And she's showing now, if you hold in the other direction, it's like kind of putting a sandwich in your mouth backwards, upside down. And she's showing where the nipple is going to the protective slot. And then again, you want to rub the upper lip with the nipple and hopefully with the little breast milk on the tip of the nipple. And when the baby opens the mouth wide, and then we bring them in. And again, chin into the breast tissue versus the nose into the breast tissue. And then you can relax the C on the breast and bring the hand around on the baby. And then that's when we ask the mom to sit back and do that laid back approach. I hope that was helpful. All right. And so the next step in that management strategy is checking for and assessing for milk transfer. And so in those first early days, you may not hear swallowing until the more copious milk comes in. So that's usually around day 4. But you are looking for that rhythmic sucking and swallowing and breathing that is happening. You may be looking for milk around the mouth. The baby's hand, the fist starts to get a little bit more relaxed. And then obviously we can use measures like weight gain. We can look at if you have a baby in the office, you can do a measurement of the baby's weight before you feed and the measurement of the baby's weight with the diaper on after they feed to see what the output measurements are, how much the baby was able to take in. But if a mom is at home, you can ask them to look at what their urine diapers look like and what the poop diapers look like. And so, really, one of the take home points is that obviously breastfeeding is dynamic. Adjustments can improve, just simple adjustments can improve latch and milk intake over time. Really taking a look at how the mom is latching the baby and the baby is nursing could be key instrumental skills in protecting the latch. I'm going to turn it over to Dr. Harley with tongue tie.
Okay. All right. Turn my camera back on and I'll try to share my screen here. Thank you, Dr. Nash. Let's see, share my screen. Share. My screen. Okay. See.
We're seeing something, just not slides yet.
Yeah, not slides. Okay. Okay. Let me, that's your slide. Oh, that's an old one. That's not the one. That's not the one I'm doing today. The one I'm doing today is, oh, shucks. Are you seeing this one?
Not yet. We're not seeing any
Okay.
slides yet.
Okay.
But yeah.
Okay. That's not the one I want to do. I mean, this is a version of it. Oh,
If if I could maybe make a suggestion that Um, if I can go ahead and do the next section while you try to figure that out,
Okay, let me
and
see.
then and or maybe send the slides to Dr. Nash so that she can share.
Yeah,
Um,
the problem is it doesn't let me share outside the organization. That's one of the problems.
oh, I see.
I
Okay.
tried. It's right here. Let me just see. This is it. Are you seeing it? There it is.
Yep,
Yes,
we
perfect.
see it.
Yay.
Okay. Okay, that's it right there. Sorry about that.
Do you want to go in slideshow mode?
Yeah, I am. I'm good right now. Okay, good. Anyway, thanks everybody. Thanks for inviting me. The DC Breastfeeding Coalition, and so I'm Dr. Earl Harley over here at Georgetown. I am a member of the AAP, um, although my dues may not be paid up. But also I'm a member of the Academy of Breastfeeding Medicine. Uh, Again, probably not paid up on my dues. So I've been involved with tongue tie and breastfeeding for, I don't know, it might be 20 years. I worked closely with Dr. Sahira Long on some projects and still working with her. So this is I'm sharing my experience here at Georgetown from the otolaryngologist standpoint. So okay, so these are my learning objectives. Um, the anatomical and functional characteristics of ankyloglossia, which is also tongue tie. This all, I mean, I go back and forth between tongue tie and ankyloglossia. As a matter of fact, I was given a talk to our department uh, a few years ago, and I was kind of taken aside by Dr. Ernie. He used to be chairman of pediatrics at Children's National, and said, "Well, you really should call it tongue tie." So I go back and forth, call it tongue tie ankyloglossia. But anyway, so then we'll differentiate the clinical significance of tongue tie from normal variations and determine when the referral is appropriate. So what is ankyloglossia or tongue tie? Is a congenital restriction of tongue mobility in the variable presentation anterior versus posterior. And I'll tell you there's some debate. Uh, if you read some of the references I'm going to quote later on, especially Dr. Messner, who used to be at Stanford, now Texas Children's, who says there's no such thing as a posterior tongue tie. I actually disagree with her. But so you're going to read that there's no such thing as posterior tongue tie. But I'll show you what I call posterior tongue tie. And then the prevalence is up to 10%. So why it matters, a lot of this we've already gone over: poor latch, ineffective feeding, maternal nipple pain and trauma, and poor weight gain. And so what I've heard sometimes from moms is that if it doesn't get better, like in 3 weeks, by 3 weeks of age, they're going to give up. That's it. You can't take the pain, the trauma, and so they just give up. And one of the other things I wanted to say, I actually mentioned this while we're talking about this, is a barrier that Dr. Nash had mentioned. One of the other barriers that I've seen on my side is that there can be no support from the partner, in other words, the husband or whoever. And I had one mom in tears who really wanted to nurse. Her husband did not support her. Her husband said, "Well, why don't you just give him a bottle?" And she literally sat in the office in tears because she wanted to nurse just that bad. So I've seen that on a couple of occasions where partners actually didn't support nursing. Anyway, um, so the clinical assessment evaluate tongue mobility and latch. We use a variety of mechanisms. I kind of have my own assessment that I do. Um, we use the latch score some, especially in the study. We're actually doing a study where the latch score is actually a before and after tool that we're using. The classification. This is the classification that most people use, and it's not Kotlow, by the way. So Kotlow is a dentist who actually I spent a day with him. He's up in Albany, New York. He's very famous in the world of laser dentistry, and probably the founder and father of it. So I spent a day with him. This is out of his book, which is online. And the book is not copyrighted, so he allowed me to use it. But anyway, so the type 1, 2, 3, and 4. And for me, type 1s and 2s are anterior, type 3 and 4 are posterior. I don't know, is my Can you see my cursor?
Yep.
Okay, yeah, anyway. So type one, so the frenum is attached to the tip of the tongue down to the alveolus. So this is the classic heart shape. You don't need a heart shape to have a tongue tie, but this is the classic heart shape right here. So these are type ones right at the very tip. Well, type two is where the frenum is like a couple of millimeters back. And then the type three down here at the bottom is a little bit farther back. And then a type four, you can't really see it. You actually have to feel it and you have to palpate. And you also can see here there's some rounding of the tongue. You can look at the shape of the tongue, the boxing, the rounding. Looking at the baby cry, you should assess the cry because you can see the tongue is restricted. The baby should be able to lift their tongue when they cry. And you can see, especially up here at the top, and they get this kind of, it's tied down in the middle, but it comes up like a stingray type. So all those are issues with mobility, um, uh, and the baby's ability to latch, to lift and latch. And and so the clinical assessment to me is not only the latch, and we have a form, an intake form that addresses all these issues, the ability to stay on the reflux, um, from the baby standpoint, weight gain, oops, and then mom's anatomy, much of this has already been addressed, but we, well, I'll talk about in a minute about how we assess. But anyway, mom's milk supply is misspelled. If mom has pain with latching, whether the pain, on a scale of 10, whether it's just with the initial latch or is it throughout the latch. Nipple injury, including just bleeding, bruising, chafing, all of that. Blocked ducts, we ask about that, and mastitis. And then the assessment of the baby. So this is one of my patients here, and I'm just showing this picture because it shows the recessed chin. And so what I came to understand is that this is a factor, the recession of the chin. And I haven't heard a lot of people talk about it, but it's a factor. And so we describe it as the unfavorable triad. Now I added my name to this, but my name initially wasn't on this. Uh, I had these drawings done by my artist here. You can see the logo down at the bottom. But artist here at Georgetown named David Klim. So David drew these for me. And then I go online and I see, well, these are my pictures. What are they doing online? So apparently somebody taken my slides and put it online. So I decided I'm gonna claim it by putting my name on it. Anyway, so the unfavorable triad. So here, actually on my left, I'm not sure if the screen is back. So you have mom with adequate length nipples. That might be a little bit exaggerated, but adequate nipples. But the point is being made here. And above that, you have a flat palate. The hard palate is flat. And you have a nice square jaw. Great latch. The lips are flanging. Great latch. Here on my right, mom with a little bit shorter nipples, maybe not reaching as far. The palate, I asked him to just make a little bit of arch just to show the difference, but also make the chin sloping. And so when these kids have these recessed chins, and the reason why the recessed chins matter is because the tongue is actually stabilized to the chin, to the mandible. If the mandible is recessed, in other words, farther back, that means the tongue is also farther back because the tongue follows the mandible. So now you have a tongue that's more posterior. The tongue itself, I'm not talking about tongue tie, I'm talking about the tongue, the actual muscle tongue. The mom's nipples are not that they could be flat or short, and the high palate is really another factor. And I always, in my assessment, I always includes all of this, including uh, just putting my finger, not only allow the baby to latch on my finger, on my pinky finger, but also just feel the palate. If it's like a deep, just kind of drops in, then that's a high palate for me. And also look at the rest of the palate. And the way I examine the baby is different. When I went to Dr. Kotlow's office and some other people, I noticed that they lay the baby flat with the baby's head in kind of in the dentist on his knees or her knees. And and I used to do that too until we almost missed a cleft palate. And we've had a couple of babies now who came in for tongue tie with cleft palates. And what I realized is when the baby is like that, you really can't see all the way back. And so I now sit the babies up, and I want to see the entire uh, uh, oral pharynx, so I can assess the palate itself, the entire, not just the hard palate, but the soft palate as well. So in favor of try it. So normal effective feeding, that can be effective feeding despite some a frenulum that looks restricted or looks prominent. But if the baby is feeding effectively, and I'll tell you what effective feeding is in our mind. But anyway, then just a frenulum that looks maybe uh, maybe a little tight, but really the baby is feeding well, and there's no restriction or dysfunction because is more function than what the anatomy. So breastfeeding in the diagnosis of breastfeeding disorder should be a functional diagnosis, not an anatomic. It's not, well, the tongue looks tight, we got to go ahead and clip it. Now, if the baby's doing well, then gaining weight, then no, you don't have to. So first line management, we've talked about a lot of this. Um, uh, Lactation consultant or SLP, depending on where you are. And I'll talk about our experience here. We have both here, um, but some systems, I think at Children's, they might rely more on the SLP, the speech and language pathologist. But anyway, somebody who's knowledgeable about lactation and positioning and things like that we've discussed today. So optimizing the positioning and the latch, and then close follow-up. We always follow our babies up, which is something we do that not everybody uh, who, not every ENT or dentist who does frenulum work do follow-ups. And I'll discuss some of the follow-ups that we've done and published on. So when to refer, persistent feeding difficulties, and sometimes it'll work its way out in terms of feeding difficulty. So I just had a baby this morning. Uh, Baby's now 9 months old. Mom had problems nursing, pain and difficulty with that, but it worked out. I mean, so the baby continued to nurse without any intervention except visiting a lactation consultant. And so the baby comes in now for a different problem, but the point was that the baby did have trouble, but it worked out, and we have some data on that too. So anyway, we're going to refer feeding difficulties, maternal pain. Maternal pain can be a big driver of what we do and why we intervene. Of course, for weight gain, we pay close attention to weight gain. What most people don't know is that I actually, before I did ENT and pediatric ENT, I actually did general ENT. So I started out as a general ENT resident. And so I have a focus that's more akin to a pediatrician, looking at things like weight gain. And so when they come back, it's not just weight gain. I'm looking at charts, you know, percentiles. Yeah, you gain, Johnny's gaining weight, but his percentiles are still maybe dropped to a few. So we look at weight gain and um, and we follow the restrictions. So we have a tongue-tied breastfeeding clinic here that we've operated for many, many years. You can see here, this is from 2019, but it's even earlier than that. And the reason I'm showing this picture, this is Michelle Lally. Michelle is a PA, but what it doesn't say in here, she's also a lactation consultant. She's a IBLC. So every patient who came to our clinic was seen by both me and Michelle. If they needed intervention, uh, Michelle would help, and then she would stay in the room with mom latching, helping mom latch. If the baby did not need intervention and maybe needed some latching support, Michelle, I would leave, go to the next one. Michelle would stay. So that was the ideal situation. Now, Michelle, uh, her husband's in the military, so they transferred. So we don't have that. And I'm looking to get it back again because it was the ideal situation. So and it wasn't an extra charge, by the way, which is how, because Michelle actually worked for us. And so we didn't, it's part of her salary to be with me on my tongue tie days. So that's an important, and we call it the tongue tie breastfeeding clinic for a reason, because our focus was feeding. In in the goals of the clinic, number one, minimal pain for mom is is almost no pain. It's never no pain, but it's always maybe a little bit of pain. Efficient feeding, and for us, efficient feeding was feeding within 30 minutes, nursing within 30 minutes. Uh, and then adequate weight gain just with nursing. Uh, and I do encourage parents to supplement occasionally with a bottle just so the baby, because we've had some babies who get so comfortable with nursing that when it's time for mom to go to work, then well, they don't want a bottle. So just know what a bottle is. But really, we would really want them to nurse. But also, it allows dad to actually participate in the feeding as well. So maybe in the middle of the night, so mom waking up, dad can do it. But anyway, so those are our goals. And so we have what we call a full service uh, clinic, and I'll explain what that means. So not only we evaluate the baby, obviously, full evaluation, and then moms, we don't, I don't personally evaluate mom, but I do ask her about your milk supply. I do, it's been mentioned earlier about surgery, either augmentation or reduction can decrease milk supply. I ask them about nipple shape, nipple anatomy. I ask them if they're using a nipple shield and all that's in, and then of course all the pain of the thing we talked about, the trauma, and all that. And then we have the handouts that we give that I have available. One is just on nipple pain, as you can see. In Apno cream, we prescribe, all-purpose nipple ointment. We've prescribed that on several occasions, especially if the baby has thrush. If pediatrician has diagnosed thrush in the baby, the mom hasn't been treated. So we'll just go ahead and give an all-purpose, like Newman's nipple cream or one of the others. But also a handout on blocked ducts. How do you manage blocked ducts? uh, massaging, the lecithin and things that we talk about. And then the galactagogue. So moms who have low milk supply, what are you doing? I mean, what supplements are you pumping? So all that's part of our evaluation. That's why I call it full service. It's not just coming in, getting your tongue clipped and walking out the door. No, we're doing a pretty good assessment. And we do have extended um, periods. I mean, it's not like a 30-minute appointment. These are because I expect the babies to feed once they nurse, or even if they don't. So we want block built into the appointment is time to feed, nurse or not nurse. So it's so for that reason, I will only see 4 new patients. I see them Tuesdays and Thursdays mornings, but I will only see 4 because it takes that much time to really evaluate the babies and have them feed as they should. When knocking
Dr.
with
Harley, you have 1 minute.
oh,
Let,
1 minute.
sorry,
Okay.
sorry.
Okay, well, let me go to something else. Okay. I want to talk about lasers versus scissors. um, lasers versus scissors. So this is a study that we just published about 6, 7 months ago that really showed no difference in terms of which I can't get it. It's published in the International Journal of Pediatric if anybody wants to read it. And this is just a chart from a graph from that. And then this is okay, just a slide from the dental literature shows before and after nipple pain. I want to get to this, the consensus statement that's pretty well quoted by Messner et al. From 2020 to talk about lasers versus, that's not enough evidence. Okay, let me go to this one. Take away. Most improved without. So this is an important point that I can end here. Most improved, many improved without surgery. And so what we did, this is our study that we're currently getting ready to publish. So we looked at kids 1 year out, both those who had an intervention and those who didn't have an intervention, 1 year out. And what we found is that the rate of continued nursing was about the same in both groups, which proves that there's over diagnosis and intervention for babies. Sometimes it just works itself out. So don't. So I think that I can leave. Oh, I got to talk about cheeks high. Cheeks high. Again, this is from that article by Mr. It says illogical. You all can read it because we have the babies coming in with possible cheek ties, and so we don't do cheek ties. But I just wanted to to dispel that. But anyway, this is okay. That's it. Thank you. Sorry, I had to rush.
No, thank you, Dr. Hartley.
Yeah,
Sorry. I mean, tongue tie in itself is a talk on its own.
yeah, yeah.
Um, there are some questions in the chat that I'll let you answer via
Mhm.
chat while we finish presenting.
Okay.
If you could stop sharing, I'm going
I
to share
just
my slides again.
stop sharing, and I'll go to the chat.
Perfect.
Okay.
Awesome. And I'm going to go back. All right. All right, Jenny, you might have to come off of mute.
I got it. Alrighty. So I'm now going to talk just briefly about food protein-induced allergic proctocolitis. And those are kids who are healthy, thriving babies. They might have some blood. They usually have blood and some mucus. And again, in healthy babies, the differential are anal fissures, Meckel's, polyps, and coagulation defects. Obviously, if the kid is not a healthy baby, the differential expands. It usually starts in the first month of life, and the cause of it is inflammation of the distal colon in response to at least one type of allergen. And the diagnosis is made by history and moms eliminating cow's milk protein. Next slide. So there are different treatments for food protein induced allergic proctocolitis. For mild uh, FPIAP without any eczema. And again, that's key because those kids are more likely to have problems with ongoing bleeding. Some countries suggest 1 month of observation prior to any dietary intervention. And that was a statement made by the Society of Pediatric Gastroenterology. And the main reason is that they felt that there was an overdiagnosis of cow's milk protein allergy, where if you looked at double-blind placebo-controlled studies, it was less than 1%, but if you asked the parents, it was about 10%. Next slide. In the US, we often will do a cow's milk elimination diet. The symptoms should improve within 3 to 4 days. It can definitely take longer. Um, and again, longer duration if the child has eczema. The parent will need to completely eliminate all milk protein, including whey and casein, and they need to make sure that they're taking adequate vitamin D and calcium. Um, and if the child's symptoms improve, the thought is to reintroduce the cow's milk protein to A, see if it has improved and resolved, and B, to kind of confirm. And this time is very variable from a few weeks in many places in Europe to what the US often does is 9 to 12 months. And about 70% will outgrow the FPIP by 1 year of age. Next slide. The pros and cons of an elimination diet. The pros is it can shorten the duration of bleeding. It can reduce the inflammation. Healthcare costs can be saved in that parents are not coming back repeatedly for concerns. And there's at least one study showing that this early FPIP can maybe predispose children later on to functional GI disorders. The cons are that it can be very tricky to manage, and any kind of little exposure can have some blood, and that can really trigger the parents. It can be very, very stressful. Again, it's often overdiagnosed. About 20% will just undergo spontaneous resolution without any change in the mom's diet, and that there is some evidence that parents will stop breastfeeding earlier because of the elimination diet. And now I'm just going to briefly chat about some jaundice so we can make sure we have some time at the end. There are two types of jaundice. There's jaundice associated with human milk feeding, and then there's suboptimal intake jaundice. The human milk feeding, also known as breast milk jaundice, it starts around 2 to 5 days, peaks around 7 to 10 days, but it can last a really long time, up to months. And again, this is in the thriving, healthy baby who's gaining weight, pooping and peeing well, and eating well. Compared to the suboptimal intake, and those are on babies who are not getting enough milk, and they have ongoing weight loss, their stools haven't changed, and they have decreased urine output. Next slide. The management, Jessica, the next slide if you can. The management of not having enough milk is to assess the latch and milk transfer, do more breastfeeding, and all the things that Dr. Nash mentioned in her child with poor weight gain, refer to a lactation specialist if needed. And if they meet criteria by the American Academy of Pediatric Medicine for supplementation, you can supplement either with maternal milk, donor milk, or if absolutely needed, a formula. Go ahead, next slide. For the jaundice associated with human milk feeding, these are babies that have unconjugated hyperbilirubinemia that can last up to 2 or 3 months. And when you look at breastfed babies at 1 month of age, almost a third of them will have a bili level greater than 5, 10%, close to 10% more than 10, and 1% will have it about 13. Um, it's associated with something particular in the birth parent's milk, and so each recurrent pregnancy will have some element of this in varying degrees. On the next slide. If the jaundice lasts more than 3 weeks, the thoughts are to obtain a total and direct bilirubin just to make sure that you're not missing a direct hyperbilirubinemia, and to look for other causes, hemolytic diseases, hypothyroidism, G6PD, which is actually one of the leading causes of jaundice these days, and then Gilbert's. Go ahead if you want to. Well, okay, actually, let me just go back one more slide. The one thing is not their thoughts are to no longer pause in the human milk feeding and to continue breastfeeding. Um, and uh, the sunlight exposure, which is sort of a common thing that pe some people will recommend. That will decrease the total bili, but there's also concern about UV and infrared radiation and dehydration and sunburn, so it's not recommended. All right, Dr. Long. Not Dr. Long, Dr. Nash.
Awesome. I'm going to quickly talk about cannabis use in human milk. And although the study is from 2018, the hot topic about this is that recreational marijuana use is has increased, and a lot of that is due to the legalization of marijuana in different states. And what we know is that the Delta 9 THC, so there was a study done in this marijuana use by breastfeeding mothers with concentrations in the breast milk. There was a study done of 50 breastfeeding moms measuring the amount of THC in the breast milk sample. The Delta 9 THC is actually the primary psychoactive compound in THC. So this is the chemical responsible for making people high. And so when it was measured in 63% of the milks, it was measurable in 63% of these milk samples, and can be there up to 6 days after the last use. And then the 11 hydroxy delta 9 THC is the compound that is measurable when THC is ingested. And that was also measurable in about 9% of the milk samples. And so all of this to say is that obviously, because there are limited studies, this was a study size of 50, but there are minimal studies. And what we don't know is because of this limited data, the potential neurobehavioral effects on infant exposure to cannabis through breast milk. The other thing to note is that most people aren't necessarily starting at the onset of breastfeeding, making it hard to tease out the effects that could happen if the mom was already using cannabis during pregnancy versus using it during breastfeeding only. With that in mind, is it okay to use cannabis? So the recommendation is to actually to have cessation and reduction during breastfeeding. Obviously, because just like the study showed, there could be more cannabis in the breast milk than in the mom's blood after the mom is actually using. also because it could possible potential for decreasing immunoglobulins and this limited and conflicting data about the acute and long-term effects. And so really, if the birth parent continues, there has to be this shared decision making on the risk of not knowing what are the neurodevelopmental effects, but also the parent understanding the benefits of breastfeeding. And then, obviously, based on the study that we just talked about, what is the route? So, is the parent ingesting? Are they smoking, or are they using both? And how often and frequent are things that have to be discussed? And so just wanted to leave. We don't have very much time, so we will make sure we share these resources, the clinical and community resources. So hopefully in a couple of weeks, the DC breastfeeding needs assessment that was done, we'll be able to share the full report. And so we can also share that out with DC AAP members when we have that report to share. But if you are looking for more information about hands-on guidance, you can use the Global Health Media Project. They have lots of free videos showing how to correct lackage in position. If you don't know how to teach a mom how to hand express, they have some great videos there. Also, there's some information on the Stanford Medicine Newborn Nursery, LER. But obviously, the AAP has some breastfeeding curriculum on training breastfeeding management. And so some of the protocols where we got the information today on common management of breastfeeding issues come from the Academy of Breastfeeding Medicine. Those protocols are free and open to access, but it also has other information on how to manage a baby who is hospitalized, who is breastfeeding, how to manage a mom who's hospitalized and breastfeeding, and other common illnesses that we may need to manage while a baby is breastfeeding. And then community-based resources. So we talked about a lot about if you aren't able to provide lactation support in clinic, then knowing the resources of where to refer moms to. Some of the common ones in the community for lactation support would be the East of the River Lactation Support Center, which the DC Breastfeeding Coalition has grant funding. It sits in the Children's Clinic at Anacostia. There is also Mama Toto Village. I know WIC provides some breastfeeding support, and also the Breastfeeding Center for Greater Washington. And if you're just looking for links of breastfeeding information, the DC Breastfeeding Coalition has a breastfeeding resource guide that's in English, Spanish, Amharic, and French on the website. But DC Health and DC WIC also have some breastfeeding resources. And so I shared all of these here. I know we don't have much time for questions, but I'm going to open the floor for questions, and if any in the chat that I can help answer. Thank you all. I know it was a lot of information. Each topic we could probably spend an hour on. Perfect. Any questions? I think we are at our 1 o'clock time frame, but happy to stay on.
I'll just jump in here, Keith Montgomery, Executive Director. So for those that are attending and are looking to claim CME, there will be a follow-up email that comes out that tells you how to claim that CME.
Thank you.
And this presentation has been recorded. You should have all seen that as you signed in. So doctors, how do you want to make that available? I can either put it on our website or by request.
The website would be great.
Yes, since we need to build out a resource section. All right, everyone. Thank you. If you have any questions, feel free to contact me or our presenters, but have a good afternoon.